Thank you so much, everyone, for your patience with me. So, very good evening and warm welcome to all the dignitaries present here. I am Momika from ClearNet, serving as the allocated session assistant to ensure a seamless experience. ClearNet stands as India's most relied upon digital platform, offering a multitude of enriching services exclusively for doctors. It is with great pride that Learned serves as a digital partner for this event hosted by the Indian College of Anesthesiologists, and the focus of today's session is the appraisal
There is some
of
echo, Momita.
journal
There is some
articles.
echo. There
Is
is
it
some
still
echo.
echoing?
Yeah.
Is it still echoing?
Yeah, now it's better.
Okay. So let's begin to the session for which I would like to invite Dr. Mukul Kapoor sir to take over. Over to you, sir.
Oh, thank you, Momita, and thank you, Clarnet, for hosting this ICA webinar. We've all again gathered here today to hear the ICA webinar. As you all know, the ICA webinars have been going on for a few years now, and we have been probably the longest serving webinar till date. And I don't think anybody in the world can match the webinars and the continuity which we have. And as we have progressed, we have organized webinars, master classes, case discussions, journal clubs, and it's never ending. And education, as you know, is never ending. And we have tried our best. The Indian College of Anesthesiologists has tried its best to ensure that good quality education is trans, uh, transmitted to all the students, all the people who gather to hear this webinar. So today we have another edition, and today's edition is based on journal articles and how to, we will have multiple presentations in which some journal articles, representative journal articles from the Indian Journal of Anesthesiologists will be presented. The summary will be presented, and then an editorial board member is going to comment on the articles. So it will be a very interesting discussion based on that. But before we go on to the agenda of the day, I would like to remind all that the Indian College of Anesthesiologists is an academic institution which has been there for many years now. And we would love all young anesthesiologists to join the academic institution because we look forward to more and more education, more and more participation from young people in the college. Because the college is meant for, transferring knowledge to people. It is not meant for any profit. It is just an organization which is useful in transferring education. We would like to remind all the viewers that we will be having the ICACon, that is the Indian College of Anesthesiologists Conference, this year in September, early September in Lucknow. The conference is being organized by the team led by Dr. Monica Kohli, and Dr. Tanmay Tiwari is the organizing secretary. Let me tell you, if you register for the conference now, not only will you get a discount as an early bird, but you'll also get the benefit of joining the Indian College of Anesthesiologists for a fee of ₹3,000 instead of paying ₹5,000. So we are giving a discount, offering a discount to people who attend the conference, and we are giving a sort of 1+1 free kind of offer, and that is something which is there this time. In addition to this, I would also like to remind the viewers, especially the postgraduate students, that for the first time, we'll be organizing a New Delhi postgraduate assembly. We are organizing it and actually designing it based on the New York postgraduate assembly, which is there every year in New York, which is very famous. And I'm sure all postgraduate students are always looking forward to the books which are published from the New York General Assembly. And this is our endeavor, an endeavor on our part, and this will be organized in Delhi, and this is being organized in end July. And the venue for this ICA, I would say it's an ICA event, so it's an Indian College of Anesthesiology event. The assembly will be GB Pant Hospital in Delhi, and we have made sure that it is not very expensive, considering the number of days which are there for this conference and considering the expenditure. We have tried to keep the delegation fee as low as possible. And we will be helping people, even getting those people who come from outside Delhi, we'll be helping them to get cheap accommodation in and around GP Pant Hospital. So I look forward to a major participation from all postgraduate students in during this event, this PG assembly, which we are holding. And I can assure you, we are choosing the best teachers, the best speakers to teach you during that period. And I'm sure it will benefit you on the long run. The case discussions, the one-to-one discussions during the PG assembly are going to benefit you tremendously. So with this introduction, I would now like to hand over the proceedings of the day to Dr. Rakesh Garg. You all know Dr. Rakesh Garg very well. Dr. Rakesh Garg is the chief editor currently of the Indian Journal of Anesthesiologists. He is an accomplished academic person. He is a person who has published more than 350 articles. He is very busy in lots of fields like the airway, resuscitation, in teaching, and in onco-anesthesia. He has written 2 books also. I'm sure all of you know him and will also recognize him very well because he's there in many teaching fora and he's always teaching people. I'm very happy that he's leading the webinar today. Over to you, Rakesh.
Thank you so much, Dr. Mukul Kapoor, sir. You have been mentor to us and we have learned a lot from you. Thank you, ICA leadership, for giving this opportunity to present some selected articles from Indian Journal of Anesthesia. And we have arena of the editors from the panel of Indian Journal of Anesthesia who will be taking this session forward. And along with me, we have Dr. Aloka Samantaray, who is professor at Sri Venkateswara Institute of Medical Sciences, Tirupati. Welcome, sir. We also have Dr. Zulfikar Ali, who is faculty at Sher Kashmir Institute of Medical Sciences, Srinagar. Welcome, Dr. Zulfikar. We have Dr. Vanita Ahuja with us from Government Medical College and Hospital, Chandigarh. Welcome, madam. We have Dr. Jason R. Doctor from Tata Memorial Hospital, Homi Bhabha National Institute, Mumbai. Welcome, sir. We have Dr. Divya Jain from Postgraduate Institute of Medical Education and Research, Chandigarh. Welcome, ma'am. So we will proceed with the first session. Over to Dr. Jason for the first article. So by the time he is joining, so the first article will be by Dr. Swapnil Parab from Tata Memorial Hospital. The Dr. Parab and the team has published an interesting article when we talk about the acute kidney injury in perioperative period, especially the cancer patient. They have published a very nice article in which we have many important outcomes which are of clinical translational value. So over to Dr. Parab.
Thank you, Dr. Rakesh. May I share my screen now?
Yes, sir.
Yeah, so first of all, I'll thank IJA and ICA for giving me an opportunity to present my paper in this particular webinar. So the article reads as Incidence of Acute Kidney Injury and its Associated Risk Factors in Patients Undergoing Elective Esophagectomy Surgery at Tertiary Care Cancer Center Institute, a Prospective Observational Study. We all know that curative cancer surgery for esophageal cancers have multiple perioperative risk factors, which include preoperative risk factors, intraoperative risk factors, and postoperative risk factors, which can collectively and individually cause acute kidney injury. Preoperative risk factors include nutritional depletion, age, higher age, comorbidities, radiocontrast dyes used during the workup of the patient, nephrotoxic chemotherapy agents. Intraoperative risk factors include hypovolemic episodes, hypotensive episodes, use of nephrotoxic analgesics, use of vasopressors during the surgery. Whereas the postoperative risk factors include nephrotoxic antibiotics and analgesics, radiocontrast dyes used during the evaluation of the complications, sepsis, and multi-organ dysfunction, which can all lead to acute kidney injury. So why did we do this study? Is as we did not have information on the rate of AKI in the Indian patient undergoing a curative surgery for esophageal cancers. Indian cancer patients definitely differ from the others with respect to low BMI, less compliance towards the preoperative optimization, and higher incidence of infective complications following a neoadjuvant chemotherapy. AKI is also considered as a marker of maintenance of intraoperative hemodynamics and normovolemia. So it also gave us an opportunity to look into our own practice of maintenance of intraoperative hemodynamics and fluid status. Our primary objective was to estimate the incidence of acute kidney injury in adult Indian patients undergoing elective esophagectomy surgeries. Our secondary objectives were to identify the risk factors for the cause of AKI and to assess the impact of AKI on the duration of postoperative hospital stay and in-hospital mortality. So we conducted a prospective observational study following an ICA approval and a CTRI registration. A written valid informed consents were obtained from all the patients a day prior to the surgery. The study commenced in October 2019 and finished in February 2021. Now, during this period, the study was halted twice. Once for the seeking approval for the reimbursement methods for the patients, and this was informed to IC. And secondly, during the COVID times when there was a national lockdown, during which many of the study team members could not be present to their duties. We included all the patients, all adult patients undergoing elective esophagectomy surgeries, the patients who were inoperable as per the surgical decision, patients who died within 72 hours of surgery, patients with a preoperative chronic renal insufficiency as recognized by serum creatinine more than 1.5 mg%, patients with a history of AKI as per the available medical records, and patients with a history of receiving renal replacement therapy in the past were excluded from the study. This was a timeline of the study where the patients were preoperatively evaluated in the PAC, and the values of the latest serum creatinine were considered as a baseline, as well as the BP recorded during the PAC was considered as a baseline BP. A consent was taken a day prior to surgery. Intraoperative data was collected during the surgery. Post-operatively, the assessment of urinary flow rates was done till the time the urinary catheter was present, which is usually by day 2 or day 3 post-operative day. And the serum creatinine was evaluated on post-operative days 1, 3, 7, 15, or the day of discharge, whichever is later, and day 28 or the day of follow-up, whichever is later. Intraoperatively, patients received general anesthesia with a controlled ventilation. Epidural analgesia was used for all open thoracotomies. Selection of IV fluids and analgesics were left to the discretion of OT anesthesiologist. Events of intraoperative hypotensions, which were defined as a drop of mean arterial pressure more than 30% of the baseline, were treated with IV fluids and IV mefentermine 6 mg or vasopressor infusions as per the judgment of the OT anesthesiologist. We used KDIGO criteria, which is laid down in 2012 for the assessment of acute kidney injury. And this criteria says increase in serum creatinine by 0.3 mg per deciliter or more within 48 hours. Increase in serum creatinine more than 1.5 times of the baseline within last 7 days, and urinary output less than 0.5 ml per kg per hour for consecutive 6 hours. It also classifies the various stages of AKI as to stage 1, stage 2, and stage 3, which has been displayed here. Post-operatively, the ICU and or the ward rounds were conducted by the study team member till the patient was discharged from the hospital or till the death of the patient. Post-operative complications were collected as a categorical data as yes or no on each particular day. Surgical complications and their severity as per the Clavin-Tinto grades were noted from the surgical database. So we planned a study for a year or 200 patients, whichever is greater. A 2x2 contingency tables were plotted for the perioperative variables against the occurrence of AKI. Categorical data were compared by chi-square test or the Fisher exact test. For the continuous data, the factors which were normally distributed, we compared the means with the independent t-test. For the non-normally distributed continuous variables, we used medians with the IQR, which were compared using a Mann-Whitney test. Variables on a univariate analysis, which had a p-value of less than 0.05, that means a significant association on a univariate analysis, and those who were significantly associated in a previously conducted studies were included for the multivariate analysis. After the multivariate analysis, we calculated the odds ratio with a 95% confidence intervals, and a receiver operating characteristic curve was plotted to determine the area under curve. So this was our the timeline of the patient, where during the study period, 258 eligible patients were there, out of which 58 patients were missed because when the study was halted. So we included 200 patients, out of which 17 patients could not be considered for analysis, as 16 of them were inoperable and one patient had died within 72 hours. So 183 patients were considered for the analysis. So these are the demographic details of the population, where the mean age was 54.4 years. Most of them were males. Patients had a low BMI of around 21.9. Most of them were ASA physical status 1 or 2 and ECOG performance status of 1. Transthoracic esophagectomy was the most commonly conducted surgery, and open approach was more commonly conducted than the minimally invasive approach. Minimally invasive approach was conducted in 67 patients. The mean duration of surgeries was 327 minutes. Our primary outcome, that is the incidence of AKI, was around 14.7%. That is, AKI occurred in 27 out of 183 patients. Stage 1 AKI occurred in 8.2%, that is 15 patients. Stage 2 AKI occurred in 7 patients, and stage 3 AKI occurred in 5 patients, that is 2.7%. As far as the impact of AKI on the perioperative outcomes is considered, we found that the postoperative hospital stay was significantly prolonged in the AKI group with a p-value less than 0.001 and odds ratio of 1.09. In-hospital mortality also was significantly more in the AKI group at the odds ratio of 13.2 with a p-value of 0.004. This was the univariate analysis in which these are the factors which were having a significant association with the incidence of AKI. This included higher age, albumin, intraoperative use of vasopressors, total blood loss during the surgery, need of postoperative use of vasopressors, requirement of mechanical ventilation, exploration under GA, anastomotic leak, postoperative arrhythmias, and postoperative pulmonary complications. When these factors were subjected to multivariate analysis, after the multiple backward imputations, we found 3 independent factors, which were requirement of vasopressors in the postoperative period, age, and anastomotic leak, which were independently associated with the AKI. We also plotted the ROC curve, where the area under the curve was 0.78. In the discussion, I would like to highlight the studies which have done a previous research on this particular aspect. So we had 4 studies done across the world. Lee et al. In 2015 had a study conducted in South Korea. Honda et al. Has a study in USA. Wang et al. Was conducted in China, and Murphy et al. Conducted the study in UK. Most of these studies were retrospective in nature. They assessed the AKI by the Akin criteria, whereas one study by Wang et al. Assessed the AKI by the KDIGO criteria. The incidence of AKI varied a lot, right from 2.4% in a Chinese study up to 35.3% in a Korean study. Various risk factors were identified, which included BMI, preoperative albumin levels, number of comorbidities, preoperative creatinine values, duration of surgeries, and dyslipidemia. So as compared to all these studies, our incidence of AKIs fell somewhere between those by the Konda et al. And by the Murphy et al. Our incidence is 14.7, which is comparable. The risk factors that we found were the higher age, the anastomotic leak, and the use of postoperative vasopressors. There are certain limitations of the study. Our study was a single-centered study with a relatively smaller sample size. We could not assess the cause-effect relationship whether the AKI led to the complications or complications led to the AKI could not be evaluated. There wasn't a long-term follow-up beyond 1 month. And the evaluation of newer biomarkers for the AKI were not done in this particular study. Although this was a prospectively conducted study, and we could identify the risk factors which are there for the AKI in a patients undergoing esophagectomy surgery. So to conclude, our study found the incidence of AKI as 14.75%. It was significantly associated with a prolonged postoperative hospital stay and increased risk of in-hospital mortality. Higher age, use of vasopressors in the perioperative period, and anastomotic leak were the independent risk factors for the development of AKI following elective esophagectomy surgery. These are the references, and with this, I conclude my presentation. Thank you. Thank you.
Thank you so much, sir.
Yeah. Thank you very much, Swapnil. That was a brilliantly elucidated talk, and congratulations for conducting a very nice study. Due to the lacuna that we have in literature for the Indian subpopulation, most of the population that is, most of the data that is reported for the Western population, and this is, I think, the first of its kind for the Indian subpopulation. So, to highlight the importance of your study, it's a prospective observational study design with the primary outcome being the incidence of acute kidney injury, with the secondary outcomes like looking at length of hospital stay and morbidity and mortality. So it would be interesting to note as to what was the average. So I saw from your univariate chart and the multivariate analysis as to amount of fluid that was given per patient roughly varied between 2 liters and 2.5 liters, I think. Right?
Yes.
And the incidence of acute kidney injury was roughly 14%. So the population was esophagectomy. The outcome measures have been clearly defined. You've used the right statistical test. Obviously, it's published, so it's gone through an extensive peer review process. And congratulations for the same. So a couple of questions that I had is, you've mentioned in your limitations that you've not used biomarkers. So it will be interesting to know what was your endpoint of giving fluids to these patients. Were all of them having an arterial transfused arterial line with something like a cardiac output monitor as to how did you gauge your fluid? So most important factors for acute kidney injury is maybe low fluid intake, hypotension. So hypotension, you can look at the vasopressor and look at the blood pressure, invasive blood pressure and titrate. But what were your guidelines for looking at the intravascular volume? So how much fluid did?
So thanks, Jason, for the appraisal. We usually maintain a little restrictive approach during the esophagectomy surgeries, as we know that these are the thoracic surgeries and there can be a sort of adverse postoperative outcomes if there is excessive fluid is administered. However, what we found was our fluid administration, average fluids given intraoperatively was around 2200 ml, which is roughly comes to around 5.5 ml per kg per hour. And it did not differ in the AKI versus non-AKI group. The second thing is we, as an institutional policy, we did not use the we did not use the starches during the as a colloids. So we mainly depend on the either gelofusine or albumin as a colloids during the as a colloid administrations. So in one of the studies which has been done by Lee et al., the colloids was identified as one of the risk factors for AKI. And maybe because we don't use starches in our hospital, maybe that could be one factor why our AKI rates might be a little lesser. So, so yes, so we don't go very restrictive. Roughly 5.5 ml per kg per hour is what we administer during the surgery. And we target our basic hemodynamics during the studies. We don't commonly use continuous cardiac output monitors for the routine esophagectomy surgery, unless we are expecting very poor comorbidities or heavy blood loss or something. Otherwise, for most of the patients, the invasive arterial line monitor is used. During a thoracic part, we cannot target the PPV or the pulse pressure variations or the stroke volume variations. But during the abdominal part, yes, we can target the pulse pressure variations. But most of our fluid administration is based on the general hemodynamics that has been mentioned.
Okay, fantastic. So I think after the chest trial, the starches have been thrown out of the bucket completely. And I think that's a knee-jerk reaction, but I think the world has moved in that direction. So very important take-home messages here that look at the blood pressure, look at the intravascular volume status of the patient, avoid any nephrotoxic drugs in case of major hemodynamics. And probably, as you rightly mentioned, the age, the comorbidities and anastomotic leaks and the post-operative use of vasopressors are one of the important factors that decide on the incidence of acute kidney injury, and you've used the right criteria. So congratulations once again, and I think I can hand over the mic to Dr. Rakesh for the next study, please. Thank you. Any other
Thank you so
questions
much.
from anyone else?
Not yet. In case if they are at the end, we'll take up again. And absolutely an
Sure.
interesting study, as Dr.
Sure.
Jason you mentioned. And thank you, Dr. Para, for contributing to the research and bringing some change in the clinical parameter. And we can think of some future research point of view that what are the predictors for those patients who have AKI that leads into the chronic kidney disease. You mentioned is as one of the limitations. And there are certain markers nowadays the NGAL studies are coming up with biomarkers.
Right.
But then we have to have some predictive models. So I think with the evolution of artificial intelligence, I think researcher group from Dr. Parab and his team can think of, can we have some predictive model of predicting certain parameters to look for those who will land up into the acute kidney injuries? Because if we can predict many models, you have already put certain parameters like use of vasopressors, A's, and other aspects. If we can have those predictive models, I think that would be a future research. Thank you so much. We will move to the next session, next topic, which is again in continuation of the post-operative complication, which is when we talk of major surgical procedures, it is always the post-operative neurocognitive dysfunction, which is always of a concern. And we have a very interesting systematic review and meta-analysis by a team of researchers across the world, and which will be led by Dr. Jitendra Kaur Makkad. Madam is a professor at PGIM at Chandigarh. Over to you, madam, for your presentation.
So good evening, everyone. Okay, so the topic of my research study is effect of prophylactic corticosteroids on post-operative neurocognitive dysfunction in adult patients, an updated systematic review, meta-analysis, and trial sequential analysis. Well, when it comes to post-operative neurocognitive dysfunction, it can be divided into two parts. One is post-operative delirium, which begins immediately in the post-operative period. It is characterized by attention disturbances, disorientation to place and time, sleep disorientation, and memory impairment. The important thing is that it starts immediately after the surgery, and there is no period in between where the patient is normal, where the cognition is good. And another thing is delayed neurocognitive recovery. This is the new cognitive impairment that develops up to 30 days after full recovery of consciousness. And there is usually a normal period between the recovery and then this develops, and it typically persists beyond the expected pharmacological and physiological effects of the anesthetic drugs. Now, PNCD, post-operative neurocognitive dysfunction, is commonly observed in the post-operative period, and it has a very high incidence of around 11 to 51%. Now, it is hypothesized that whenever there is surgery, there is surgical trauma and there is release of inflammatory mediators. These inflammatory mediators cross the blood-brain barrier, cause some inflammation in the brain, which results in the post-operative neurocognitive dysfunction. Corticosteroids have been utilized in the postoperative period to attenuate incidence and severity of postoperative neurocognitive dysfunction. There are several studies on it, and they have been conducted in various scenarios. Like in cardiac patients, the incidence is high, so most of the studies are limited to cardiac scenarios. Coming to the meta-analysis, there are one or two previous meta-analysis, but they have again been conducted in cardiac patients. So we thought, like, the research question which came to our mind was that is there any role of corticosteroid, be it dexamethasone or something else, in preventing PNCD in patients undergoing any type of surgery, irrespective of the type of surgery, be it cardiac surgery or be it a non-cardiac surgery. So we got the trial, our thoughts registered with Prospero in the month of June 2022, and then we followed the PCAUSE criteria to define the methodology of our systematic review and meta-analysis. We included studies, RCTs, which enrolled adult patients more than 18 years of age undergoing surgery under general anesthesia. And in the intervention group, patients received corticosteroids during the perioperative period. Vice versa, the study should have had a control group where comparators did not receive any steroids. And we looked for the studies which had reported incidence of postoperative neurocognitive dysfunction within 1 month. And the timings of the study should have been those which had followed up the patients for at least 30 days and should have been conducted in the perioperative settings. So our inclusion criteria were RCTs which compared corticosteroids with a placebo or no steroid in the perioperative period. We excluded studies that involved pediatric patients, animal populations. We excluded non-randomized trials, and then we also excluded trials which had compared two doses or two different types of corticosteroids without a control group. The primary outcome was the incidence of postoperative neurocognitive dysfunction at 1 month, while the secondary outcomes were severity of delirium, use of antipsychotic medications, postoperative infections, mortality, and the length of hospital stay. We searched PubMed, Embase, Scopus, and Cochrane using the search words cognitive dysfunction and delirium or PNCD and corticosteroids or dexamethasone or methylprednisolone and postoperative period, so that we could cover all the articles. Data extracted included trial designs, publication year, number of patients, type of surgery performed, the type of corticosteroid used, measured doses and outcomes. While the type, we also recorded data on the type of control treatment, mode of intraoperative anesthesia, and then coming to the primary outcome, what was the incidence of delirium, what was the scoring system used to record delirium, what was the severity of delirium, did patients need any antipsychotic medications, and was there any postoperative infection or any other complication because of the steroids, the length of stay in the hospital, and the mortality associated with postoperative neurocognitive dysfunction. Risk of bias of the enrolled trials was assessed using ROB2 criteria that have been defined by Cochrane, and this included, was there any problem with the randomization process, deviation from the intended intervention, missing outcomes, measurement of the outcome, and the selected reported outcomes. Overall, ROB were expressed as low risk, some concerns, or high risk. And then we graded the evidence, the quality of evidence using grade recommendations. And then all the pooled outcomes were categorized as whether they were of low quality or high quality. CMA 3.3 was used to perform the statistical analysis. Continuous data was reported as mean differences and odds ratio for categorical data. Heterogeneity in the trial was assessed using I2, and if the heterogeneity was less than 50%, we used a fixed model effect, otherwise a random model effect. Forest plots were generated. In case of trials which had in case of any outcome which was reported by less than 3 trials, we did a qualitative reporting, or in case any outcome had less than 100 patients, again a qualitative recording was done. Publication bias was assessed using funnel plots. We did a subgroup analysis for the type of postoperative neurocognitive dysfunction, the effect of surgery on the type of postoperative neurocognitive dysfunction, and the incidence of postoperative neurocognitive dysfunction. We also we could not do a subgroup analysis on the doses of steroids and types of steroid because there was a limited data. So trial sequential analysis was performed for the primary outcome to see whether the results which we were getting had an adequate sample size. So this is the flow diagram which showed that we came across 9178 articles in our initial search. Then we removed the duplicates. We extracted the abstracts for 224 articles, and then only 22 articles fulfilled our final eligibility criteria. Out of these, 7 were excluded because they did not give the relevant information, and data was analyzed for 15 trials. And this is the table of all the trials which we included. There were around 7 cardiac surgeries, and rest of the trials were non-cardiac surgery trials. The primary outcome was the incidence of PNCD, and we found that the use of steroids was associated with the pooled odds ratio of 0.7 as compared to control, and the grade of evidence for this was moderate. And the p-value for the results was 0.02. We did have a heterogeneity of 66% for this outcome. And this is the risk of bias, quality of risk of bias. So all the trials were at low risk of bias except for one trial which was at a high risk of bias, and there was one trial which had some concerns. And the below chart shows the publication bias. There were hardly any trials which had publication bias in those trials which were enrolled by us. Coming to the secondary objectives, there was a significant decrease in the incidence of post-operative delirium with the use of steroids. But when it came to post-operative neurocognitive dysfunction from 48 hours to 30 days, there was no significant effect of steroids on that. So this is for POD and this is for DNCR. And overall, there was a significant difference, as I've already told in my primary outcome. Coming to the type of steroids and surgery, there was no significant benefit of steroids in the patients, depending upon whether it was a cardiac surgery or a non-cardiac surgery. So there was no effect of surgery on the efficacy of steroids. Coming to post-operative antipsychotic medication requirement, there was no difference in the need for post-operative antipsychotic medication requirement between the two groups. Severity of PNCD was lower in patients who received dexamethasone, and there was a significant difference in the length of hospital stay with the use of corticosteroids. Corticosteroids decreased the length of hospital stay, probably because they decreased the incidence of delirium in the patients. There was no significant increase in the risk of postoperative infection with the use of steroids, and there was no significant difference between the two groups regarding the 30 days mortality. This is a graph showing the trial sequential analysis, and then we saw that 18445 patients were required to to get an adequate sample size, and the sample size which we had was 15308. This indicates that probably the number of studies are still not adequate to say whether the dexamethasone or any steroid has a significant role in decreasing the incidence of postoperative neurocognitive dysfunction. And more trials are warranted before we can really say that the drug is helpful. I would like to emphasize on this point because there is a literature which goes against the use of dexamethasone. But when we conducted this meta-analysis, we were of the opinion that dexamethasone is a very important drug because we can use it day in and day out because it is used for PONV, it is used for decreasing airway edema. So such an important drug, if it has a role in neurocognitive dysfunction, reducing neurocognitive dysfunction, it should be thoroughly studied before it is ruled out as a drug of importance. So coming to discussion, moderate quality evidence suggests that corticosteroid has a statistically significant protective effect on PNCD. However, more RCTs are needed before a definitive answer regarding the effect of steroids on PNCD can be achieved. Another important thing is that postoperative neurocognitive dysfunction cannot be attributed to a single factor, like it is only the steroids. If we administer steroids, probably we will be able to decrease it. It depends on multiple factors, and we need to take care of all the factors if we want to decrease the incidence of postoperative neurocognitive dysfunction. Patient age, preoperative cognitive functions, major cardiac or non-cardiac surgeries, hemodilution are few of the other precipitating factors, and they should also be taken into consideration. Another thing is that all the studies have been conducted in low-risk population, so it is important that we start having protocols trying to study patients who are at high risk, like patients who undergo hemiarthroplasties after falls, patients who are more than 80 years of age, and then we need to study the bundled approach rather than a single approach. Corticosteroids is only one component of the approach. Coming to the limitations, the meta-analysis has limitations as it has for any meta-analysis, like there is heterogeneity in the outcomes. We had heterogeneities vary from 50 to 60%, but then it all depends upon where the studies have been conducted and what type of patients were enrolled. And another limitation is that it cannot be applied to high-risk population because most of the trials have been conducted on low-risk populations. So to conclude, our meta-analysis revealed statistically significant protective effect of use of corticosteroids. TSA revealed that adequate effect size was still to be achieved. PNCD has multifactorial etiology, and so we need to take care of, we need to have further RCTs which take care of other parts also. So with that, I conclude my presentation.
Thank you so much, madam. This is a very well conducted meta-analysis published in Indian Journal of Anesthesia, wherein in the surgical patient, the authors have tried to look for its beneficial effect with regards to dexamethasone. The trial sequential analysis shows that there is still some more studies to be required, but the directionality is giving a hint that it is protected. And I think using single dose, which they have seen in many of these patients, probably are beneficial, and so is beneficial for other effects. Dexamethasone has been found to be good for PONV. It has been found to reduce the opiate requirement when we are talking about opiate sparing techniques nowadays because of the some effect on the outcome of various surgical procedures. And the ill effect of single dose of steroids, which was earlier considered as increased risk of infection, sugar derangement, all those things are not seen. So I think we need more robust RCTs, not only to look for single parameter of POCD, but also the delayed neurocognitive dysfunctions. Majority of time, the studies which are published nowadays are talking about the immediate outcomes within 24 hours, or sometimes at the maximum within 48 hours. I think this is the right time to also to look for the delayed outcome at 30 days, 6 months, and a year, because many of the anesthetic concerns had effect on those aspects also. Similarly, we also need to think of if we translate this meta-analysis and research into a critical care setup, where sometimes the steroids would be required for a longer duration. Therein, the steroids has been found to increase the incidence of delirium. So on one side, we say short-term it is beneficial, but on long-term in ICU setups, or those who are working in cancer setup for, say, brain tumors or radiation therapy where steroids are given, they increases the chances of delirium in these patients. So we need to look for that. What is the optimal dose? What is the optimal duration, which will be beneficial to the patient and which will be harmful to the patient? Maybe
Exactly.
we can say, yeah, Dr. Jitendra.
Yeah, exactly. So what we need to define is what is the optimal dose, how many times in a day, and for what duration can we give it. And another important thing is that this drug is coming up in a big way for rebound pain after peripheral nerve blocks. So with all those advantages and disadvantages, we really need to work on a couple of things, the dose and the duration. Yeah.
Perfect. I think a lot of questions has come up. I am sure the listeners who are listening to us will get at least 5 research questions to do a research and get it published in Indian Journal of Anesthesia. Thank you, Dr. Jitendra, and we'll move to the next session. I hand over the session to Dr. Aloka Samantaray, editor ICA.
Thank you, Dr. Rakesh.
Thank you, madam.
Yes, Dr. Sukhanti.
Yes, sir.
With your presentation, please go ahead.
Yes. So I'm sharing my screen. Is it visible, sir?
Yes, please.
Yeah. Thank you very much, ICA and IGA, for presenting us this opportunity to present our article, which is an original article published in the March issue of IGA. The title of the article was The Comparison of Acute Physiology and Chronic Health Evaluation to Score an American Surgeon National Surgical Quality Improvement Program Scoring System in Predicting the Postoperative Mortality in Patient Undergoing Emergency Laparotomy, a Retrospective Study. Emergency exploratory laparotomy is a common surgical procedure which is conducted worldwide, but this is associated with significant mortality and morbidity. Perioperative risk stratification is very vital in this group of the patients because it allows for initiation of the targeted intervention that will improve the outcome of the patient. In cases of the elective surgery, the common risk stratification tool is the ASA grading, but its role in the emergency surgical procedures is not very clear. As a result of which, various other risk stratification tools have been proposed. However, the optimal risk stratification tool is still unknown, and there is paucity of data from the Indian surgical patients. So we conducted this study with a research question that compared to ASA grading in patients who are undergoing emergency exploratory laparotomy, do the Apache 2 score and ACS NSQIP surgical risk calculator perform better in predicting the perioperative outcome in this group of the patients? The primary objective of our study was to assess the accuracy of preoperative Apache 2 score, ACS NSQIP risk calculator score, and AC grade in predicting the postoperative 30-day mortality of the patient. And the secondary objective was to assess the accuracy of these risk stratification tool in predicting the postoperative complication. Our study was a retrospective study which was started after obtaining the ethical approval and trial registration. We included the patient who underwent emergency exploratory laparotomy for peritonitis following the perforation of hollow viscus, who presented to our hospital from July 2022 to December 2022. We included the patient with age between 18 to 80 years of the age, and those patients who are coming for the repeat surgical procedure, those living with the HIV infection, or the patient who are receiving the immunosuppressive medications such as long-term steroid or chemotherapeutic drugs were excluded from the study. For this study, we retrieved the case report of the patient and the details were evaluated, and we noted the various preoperative, intraoperative, and the postoperative details. The preoperative details that we included are the demographics, the comorbidities of the patient, and depending on their preoperative clinical variables and the laboratory variables, the AAC grading, APPRAISAL scores, and the ACS scores were calculated. Intraoperatively, we recorded the type of the anesthesia, the site of the perforation, the type of the surgical procedure that was undertaken, and the intraoperative blood loss. In the postoperative period, the outcome of the patient at 30 days after the surgery and the postoperative complications were noted. For the statistical analysis, we used the SPSS version 25. The continuous variables were expressed as mean and standard deviation, and the categorical variables were expressed as number and percentage. The normality of the data were checked, and depending on the normality, either the independent t-test or the Mann-Whitney test were utilized, and the p-value of less than 0.05 was taken as statistically significant. To assess the predictive accuracy of APPRAISAL score, ACS NSQIP score, and AAC grading, we plotted the receiver operating curve, and the area under the curve was determined. To further assess the association between these risk stratification scores and the outcome of the patient, we performed the logistic regression analysis, in which the mortality of the patient at 30 days after the surgery was kept as the dependent variable, and the risk stratification scores APPRAISAL, ACS, and the AAC grading were kept as the independent variables. To determine the calibration of the model, we performed the Hosmer-Lemsau test for the goodness of the fit, and we also determined the calibration of the model. For this test, if p-value is more than 0.05, it means that there is no statistically difference between the incidence of the expected and the observed outcome, and the model is good calibrated. Now coming to the results, during the study period, a total of 472 patients underwent exploratory laparotomy, out of which the 60 patients, they fulfilled our study criteria. Here we can say that the majority of the patient has a mean age of around 40 years, and majority of them were males. Looking at the ASA grading distribution, out of the 60 patients, 29 patients belong to the ASA E1 grade, whereas the 20 patients, they belong to the ASA E2 grade, and 11 patients belong to the ASA E3 grade. The most common site of the bowel perforation was the small bowel, followed by the stomach perforation, and the commonest surgical procedure that was undertaken was bowel resection with the stoma formation. Now, looking at the outcome of the patient, at 30 days after the surgery, the mortality was seen in 23 patients. 25 patients experienced the postoperative complications. 21 patients also required the need for the mechanical ventilation. Out of these 21 patients, 19 patients had poor preoperative chest condition because of the disease process, and 5 patients also had concomitant preoperative AKI. The most common postoperative complication that was noted in our patient were the septicemia, followed by surgical site infection, burst abdomen, and AKI. The APPRAISAL scores, ASA grade and the ACS score were compared between the survivors and non-survivor, and the difference was found to be significantly different. However, on the ROC curve, we found that the area under the curve for APPRAISAL score was 0.737, which indicates that it has a satisfactory predictive accuracy, whereas the area under the curve for ACS, NSQIP score, and ASA grading was less than 0.7, indicating that they are poor in predicting the outcome of the patients. Now, for the postoperative complications, the APPRAISAL scores, ACS score, and ASA grade were found to be significantly different between the patient who developed postoperative complication compared to those who didn't. On the ROC curve, the area under the curve for the APPRAISAL score was found to be 0.77, whereas for ACS and the AC grading, the AUC was less than 0.7. Now, based on the ROC curve, we determined the optimal cutoff for the APPRAISAL score, and it was found to be 6. At the cutoff point of 6, this scoring system has a positive predictive value of 65.4% and negative predictive value of 82.4%. On logistic regression analysis, we found that Apache 2 score has a significantly strong association with the outcome of the patient as compared to the ACS score and the ASA grading. The post-hoc power analysis of the study was calculated, and assuming a sample size of 60 with an effect size of 0.5 and alpha of 0.05, the post-hoc power of the study was found to be 86.6%. So in this study, we found that the area under the curve for Apache 2 score for predicting the 30-day mortality of the patient was satisfactory. It was 0.73 for mortality of the patient and 0.799 for postoperative complications. So similar to our finding, the previous studies had reported the area under the curve for Apache 2 score to be ranging from 0.76 to 0.98. So this indicates that in this subgroup of the patient, the outcome, apart from the comorbidities, depend on the derangement on the physiological variables because of the disease process and also on the age of the patients. The ACS NSQIP surgical risk calculator has a poor predictive accuracy with the area under the curve of 0.6 for mortality and 0.68 for the postoperative complications. So this finding is different to what we find on the data that is based on the Western population. So we attributed this difference because of the variability in the clinical presentation of our Indian surgical patient. Our patient, they have a very different profile compared to the Western population. In the Western population, the perforation of the distal gut is more common compared to the proximal gut perforation, which is seen in our patients. And also, in our scenarios, the patient, they present quite late to hospital for their treatment. By the time they present to the hospital, a significant proportion of them have developed septicemia and peritonitis. So because of this, that it could be a difference in the ACS score that we have noted. But based on this, there are certain limitations of our study. It was a retrospective study that was conducted on a small number of the patient. And we only included those patients who are presenting with the hollow organ perforation. Other patients who are coming for the laparotomy with the other etiologies, such as intestinal obstruction trauma, were not included. And this study was conducted in a single center located in the urban area of the area. And it may not be reflective of the picture of the rest of the country. So we conclude that for patients undergoing the emergency laparotomy, the Apache 2 score has better discriminative ability for mortality and development of the postoperative complication compared to the ACS NSQIP risk calculator and the AAC physical status classification. So with this, I conclude. Thank you very much.
Thank you, Dr. Sukhanti and the team MAMSI for this well-designed study. So the study again, the study again looks into comparison of three variables. Actually, one is your Apache 2 score, which looks into 12 physiological variable, and the NSQIP score, which look into 21 variables, and the ASA physical status. It's not actually ASA physical status; it's the emergency ASA physical status, and they have compared these three, and they come out with the finding that the Apache 2 stood best with an area under the curve almost 0.73 for the mortality and 0.79 for the morbidity, respectively. So they also established a very good fit model for both Apache and NSQIP, but not for ASA physical status. So far mortality is concerned, but when they looked into the post-operative morbidity, here all the three score were having good fit with P more than 0.05. So here the author has again re-emphasized the importance of using Apache 2 score from the ICU to the operation room setup. As explained by Dr. Sukhanti in the limitations, they have also left many questions to be sorted out or to find out in the prospective research by looking into or taking a larger sample size. Here they have used a post-hoc power analysis, which has its own limitations. So probably a prospective and estimated sample size would be much better to come out with more results. And probably Dr. Sukhanti can answer this. They remain silent about the table 4, what I could see in the manuscript. So how would be to compare the different ROC curve what we got with three variables to find out which is good and which is bad? to predict your observed and expected outcome. You have mentioned something in table 4, but you have remained silent for that in your method section, the result section.
Table 4 for this logistic regression, sir.
Yes, you have mentioned something like wall statistics or something. Can
Yes,
you
sir.
explain
So in this table, we can see that we kept the dependent variable as the postoperative mortality of the patient at 30 days after the surgery. So Apache 2 score, ACS, NSQIP score, ASA score, all of them has a p-value of less than point, except for the ASA score. The both of Apache 2 and ACS score has a p-value of less than 0.05. So these are statistically significant. And the odds ratio, it means that with the increase in the Apache 2 score and the ACS score, as the value of this scoring system increases, the mortality of the patient increases by 1.17 times when we use the Apache 2 score, and it increases by the 1.21 times when the ACS score is used. Similarly, when we look at the postoperative complications, Apache 2 score and ACS score has p-value of less than 0.05 when we want to predict the postoperative complication by using this scoring system. So they have a positive correlation with the outcome of the patient, that is the occurrence of the complications. Unit increase in the Apache 2 score will increase the chances of patient developing the complication by 1.2 times, whereas the increase in the unit value of the ACS scoring system will increase the chances of developing the complication by 1.3 times.
Yeah, I have one more query actually. If I look at your table 2, what I found is your this Hosmer-Lemso test, which looks for observed and expected event rate. I don't find much difference between Apache 2 and ASA, whereas it's just 0.05. That means if it is more than 0.05, we say it reject null hypothesis, and the ASA it's 0.045, whereas you have given good for this good fit for the ACS NSQIP. Can you comment on this?
Yes, sir.
It's
So, sir, Hosmer-Lemso test that will basically determine how well the model that has been created by the logistic regression will fit well. It means that if the value of this p-value that is obtained by the HL test is equal to 0.05 or more than 0.5 times, then the risk which is predicted by the Apache 2 score compared to what we have actually observed in our patient subgroup, there is no statistically difference between these two. Whereas ASA is just falling short of the 0.05. It means the risk that has been predicted by the ASA is not similar to the risk which we have actually observed. So Apache 2 score is better calibrated. It means the risk which has been predicted by the Apache score and those by the ACS score has better correlation in terms of the prediction which has been done by the scoring system and what we actually observe. Since this p-value for ACS score is less than 0.05, it is not, we do not find it to be very well calibrated. The ACS score and the Apache score has a p-value of more than 0.05. It means there is no difference between the risk which has been predicted by these two scoring systems and the risk which was actually observed in our study population.
Yes, I too believe that is a very good fit actually. So in that case, the NSQIP got a good mark with 0.25 compared to 0.05.
Yeah, that is more calibrated compared to the Apache 2 score.
And the Apache 2 score. I once again congratulate you for a very good study. I have only one thing that probably future studies can be done with a prospective and a larger sample size and defining the postoperative complications so that you can pick up the actual number of complications by either employing something like Levin-Dindo or some defined postoperative complications.
Sure, sir. Actually, we planned this study as a prospective study, but there are certain ethical issues that were raised because these patients are very vulnerable kind of the patient. Whenever they come to the for the surgery, they are in pain. Some of them may be disoriented. So there was an ethical issue in taking consent from these patients. So we conducted this study as a retrospective study.
Thank you. Thank you. Over to Dr. Rakesh.
Thank you, sir.
Thank you, Dr. Aloka Samantaray, and thank you, Dr. Sukwanti Kerai and the research team from Palanajat Medical College. We now move to the next one. Over to Dr. Vanita Ahuja, editor ICA.
A very good evening to all, and thank you, ICA and Dr. Rakesh for inviting me for this good webinar. I would like to invite Dr. Mridul Dhar from AIMS Rishikesh, and he would be speaking, is presenting his original article, a randomized trial comparing block characteristics of a mixture versus sequential injections of lignocaine and ropivacaine for supraclavicular brachial plexus nerve block in patients undergoing upper limb surgery. So, Dr. Midul, you can present your original article.
Thank you, ma'am, and thank you to the ICA educators and IGA journal, including Rakesh sir, for the opportunity to let me be part of this webinar. Quickly get into the summary of our article. This is an article published in IGA called as a randomized trial comparing block characteristics of a mixture versus sequential injections of lignocaine, ropivacaine for supraclavicular brachial plexus nerve blocks in patients undergoing upper limb surgery. The introduction. So we know that the lipid-soluble local anesthetic agents like ropivacaine and bupivacaine generally have a significantly longer duration of action, as well as a more prolonged onset of action compared to intermediate potency drugs like lignocaine, mepivacaine, and prilocaine. Combination of two LAs are often used in regional blocks to utilize the different properties to achieve a faster onset and a longer block duration. Although mixing these two drugs is relatively common in clinical practice, there's not much literature on use of sequential injections when they're using in combination. So we targeted this research question, that does a sequential injection of lignocaine followed by ropivacaine in supraclavicular brachial plexus block lead to a faster sensory block onset compared to a mixture of these two drugs? The primary objective was to compare the percentage of patients with a complete sensory block at 10 minutes after the block injection between these two groups of lignocaine and ropivacaine. The secondary objectives were to compare the percentage of patients with first sensory and motor block onset as well as complete sensory motor block at various time intervals from the block till 30 minutes. Other objectives were to compare the block procedure time between the two, total duration of sensory and motor block, duration of analgesia, and complications between the two groups. Methods, ethical approval was taken from the Institute Ethical Committee. The trial was registered with CTRI in 2020. The design was a double-blind randomized trial, which included patients aged 18 to 70 years of all genders, weighing 60 kg and above, planned for unilateral upper limb surgery under USG-guided supraclavicular brachial plexus block. We excluded patients who refused to be part of the study: coagulation, bleeding disorders, local site infection, any nerve injury, neuropraxia or paralysis, history of allergy or anaphylaxis to the study drugs, pregnant females, difficult or abnormal sonoanatomy, and block failures due to any technical reasons. After recruitment, patients were randomly assigned to any of the two groups using a computer-generated random sequence. Allocation concealment was done using sequentially numbered opaque sealed envelopes. The patient and the outcome assessor were blinded to the group allocation. On the day of the surgery, IV midazolam 1 mg was given for angiolisis in the preoperative area. The block was performed in a pre-op block room near the operation theater with appropriate monitoring and resuscitation equipment. The anesthesiologist and the assistant performing the intervention opened the envelope to prepare drugs and equipment for the block. The block technique, a high-frequency linear ultrasound probe, was used for the procedure and for the scanning. Cleaning and draping of the area of the injection site were performed. 1 ml lignocaine with adrenaline was injected for skin infiltration. The block needle of 22 gauge of appropriate length was inserted from a lateral to medial direction and in plane technique. The drug was injected in the lower and upper part of the supraclavicular nerve plexus. Brachial plexus. The drug used was 15 ml each of 2% lignocaine with adrenaline 1:2 lakh and 0.75% ropivacaine. The interventions were group S, which is the sequel injection technique, in which 15 ml of 2% lignocaine with adrenaline was injected first, 7.5 ml each at the 2 points of the plexus, upper and lower, followed by the injection of 15 ml of 0.75% ropivacaine with the intent to surround the lignocaine drug already deposited. In the group M, which is the missed injection group, 30 ml of the mixture, a freshly prepared mixture of both LAs was directly deposited, first in the lower part of the cluster, followed by the upper part, 15 ml each. The outcome assessment was done using a 3-point scale for both sensory and motor blockade, in which 3 was normal sensation to pinprick or motor function, and 1 meant no sensation. and complete paralysis. 4 areas, 4 nerves were analyzed: musculocutaneous, median, radial nerve, and ulnar nerve for both sensory and motor. The primary outcome was the percentage of patients with a complete sensory block, which is 1 in all 4 nerves at 10 minutes post-injection. Secondary outcomes were onset and complete sensory block at various time intervals till 30 minutes post-block for both sensory and motor. Duration of analgesia, which is the block performance to the first request for analgesia post-operatively. Duration of sensory block, which is from the block till sensory score of 3 was observed in all 4 nerves for sensory and motor, and complications were measured. Definition of some outcomes: the onset of sensory block or motor block was defined as a sensory score or motor score of 1 in any of the 4 nerves measured, and a complete sensory block was defined as a sensory score of 1 in all the 4 nerves. A failed block was when the conversion to general anesthesia had to happen or a supplemental block was required. These cases were not considered in the final analysis. The sample size was calculated based on a study where the percentage of subjects with a complete sensory block was 57% at 10 minutes post-injection of a mixture of lignocaine and ropivacaine for supraclavicular brachial plexus block. To be able to detect an increase in this rate to 90% at 10 minutes with a sequential technique, 27 participants in each group were required to be able to reject the null hypothesis that there is no difference between the two techniques, assuming a 5% alpha error and an 80% power. So taking 20% block failures and dropouts, 33 in each group were finally calculated. For statistics, we used GraphPad Instat version 3.05. Data was compared using the unpaired t-test or Wilcoxon rank sum test based on the normality of distribution of data. Categorical data was analyzed by the Fisher exact test, and p-value less than equal to 0.05 were considered significant. Coming to our consort flow chart for patient recruitment, a total of 70 were initially analyzed for eligibility, 4 were excluded, and finally 33 in each group were randomized. Finally, we analyzed 32 patients in each group. 1 each was removed from analysis because 1 required a rescue block and 1 required to be converted to GA. Coming to the demographic and operative data, we can see between the 2 groups, it was comparable. The demographic data as well as the operative type of surgery and duration of surgery were all comparable between the 2 groups. Coming to the primary objective, which was percentage of participants with a complete 4-nerve sensory block at 10 minutes post-injection, we observed that there was a statistical difference. There was a higher percentage of patients in the sequential group, which had a complete 4-nerve motor block, which is 69% compared to 41% in the mixed group. Secondary objectives, looking at the overall trend of time period between the block to 30 minutes, sensory score of 1 in any of the 4 nerves, as well as complete 4-nerve block, onset and complete block. We can see a general trend of the sequential group patients having higher blockage, but this trend we can observe at the end of 30 minutes was minimal. Coming to the duration of analgesia between the 2 groups, duration of complete sensory and motor return, as well as the block procedure time, they were all comparable between the 2 groups. There was 1 case of Horner syndrome in the sequential group, which was resolved by the end of the surgery. Discussion, similar studies using sequential techniques, but using different drugs or blocks by Ruberman et al. And Gunjal et al. Had similar findings of comparable total duration of sensory motor block. But in the current studies, there was a higher initial sensory block in the sequential group, which is in contrast to the above studies where they got similar onset and complete block durations. This possibly recreates that duration of action is related to the total dose of the local anesthetic, either as a mixed or a sequential injection, even if there are differences in the initial block characteristics. Also in the current study, at the end of the block assessment period of 30 minutes, the group M, which is the mixed group, had a higher percentage of patients who failed to achieve a total 4-nerve sensory or motor block compared to group S, which is perhaps a reflection of the density of the block, which may be compromised due to drug dilution in the group M. However, these did not lead to any block failure or issues during the surgery in those patients. The limitation of this study is that this study is only applicable to the use of combination of local anesthetics. We do not use a single anesthetic agents like ropivacaine, which can be further explored in future studies, because ropivacaine in a higher percentage of 0.75% also has a faster onset. So to conclude, in this study, compared to a mixed injection technique, the sequential injection of lignocaine and ropivacaine has a higher rate of sensory and motor block onset initially, but the difference is minimal at 30 minutes after block injection. Both groups have a similar total duration of sensory and motor block as well as duration of analgesia. These are my references. Thank you very much.
Yeah, thank you. It was a very good presentation, Dr. Mridul. The study is a well-conducted study. It is a randomized control trial. It had a comparator group. Then you have done the ethics approval, the CTI registration. So for the residents, like all these things are very important. And you have followed the good clinical practices, and that you followed all the. My one question is there that what was the, since you have yourself mentioned that there are several studies in which no difference was seen, so why do you think that there was a difference in your patients when for the sensory block at 10 minutes and the motor block? So what is your take that why did you get that difference of like in your patients, like you had a 69%, so why did you get that favorable result in your study?
Ma'am, one possible thing which I think is probably a little bit of difference in methodology, because those other studies, even though there were very few of them doing sequential, but they were measuring the time to onset of block. For us, because of feasibility issues, we could not measure the exact time. So we were measuring the percentage of participants getting a complete or onset block at various time intervals. So in that way, we were just extrapolating that the concept is similar, but the exact outcome was not the same. So perhaps that's why, in terms of the percentage of patients getting a block, we got a little higher percentage in the sequential group. But again, as we noticed at the end of 30 minutes, the difference was very minimal.
Yes. There are several, studies. One thing is that you have mentioned about the sequential, use of the local anesthetic. First, you used lignocaine with ADR and then followed by your 0.75% of ropivacaine. There's another, aspect to it, like the number of needle passes. I think you mentioned like you have given first, a volume of lignocaine at the upper part, then at the lower part, and then you again pass the needle for your ropivacaine. So there were 4 needle passes in one group and there were 2 needle passes in the other group. Now that has, another aspect to regional anesthesia where, we know that the supraclavicular brachial plexus can have certain septate barriers. And once you do number of needle passes, you may be, going for a uniform spread of the drug, and which can, give a better block in these patients, which can be. So this is one aspect that we can, look into it.
There's another aspect of more needle passes having more complications as well. So that we have to balance.
That's why I was just coming to that as well. And because then you have to be careful for your pneumothorax, and you have to be careful, that every time that you put the needle, you need to aspirate. So intravascular, injections and your pneumothorax, these have to be taken care of. But yes, there have been studies about triple, injections, triple insertion of needles. Also, it is there in the literature, and they have shown higher results as compared to safe. So that is one more aspect to maybe you might have got those results in your patients. And the other aspect is that when you did a sample size, it was like you expected an increase like from 57% to 90% at 10. You anticipated that you're getting a higher percentage, like 90% at 10. 90% of the patient would be having a complete sensory blockade at 10 minutes. But in reality, it was lower than that. Like it was 69% versus 41% in your sequential group 69% and your mixed group had a 40. And that is why probably the p-value was also 0.04. I mean, I would say that it's like it had been 0.049, so it had come almost to 0.05, So that also needs to be looked into. Then the type of surgeries which were included were like elbow surgeries and wrist surgeries.
It was a mix of plastic surgery, orthopedic surgery.
Yeah. So I could not see the cohort of patients, like how many diabetics were there, how many patients had ASA grading 1, 2, 3, or 4. I mean, that also sometimes influences, that can be a part of it's a part of limitation, or maybe we are choosing a cohort. So that is kind of a uniformity. We can look into it. And then the type of needles, yes, that is, you maintained a uniformity in the type of needle, because needle bevel is also very, very important once you're giving regional anesthesia. And then one more thing which we can always, increase for the safety is that we either use a pressure technique while injecting, or we need to have some kind of a monitoring whether we are not injecting into intraneurals in
We can assist
sake of
using
sex.
PNS
Yeah,
technique as well.
absolutely, absolutely right. And the conclusion also, is on the sensory and the motor onset. But we were looking at the sample size with the 4 nerve blocks at 10 minutes.
Yes.
So that needs to be correlated with the hypothesis, and the conclusion needs to be, kind of correlated with it. But overall, a very good effort and a very good, attempt to have a scientific basis to what is being done traditionally since so many, we have already been doing, but giving it a good scientific, justification to this technique is well appreciated.
Thank you.
Can I make a comment, please?
Yes, Dr. Mrityunjay.
Sir, I happen to be the co-author for this Gunjal et al. Study that is quoted here. So I just want to say that what happens during mixing of local anesthetic, if you're doing 1:1 mixing, the dilution of the concentration will go down. So the effectively the nerve, what is reaching there in at nerve to act, that has got lesser concentration. So that is one factor that actually influenced the outcome in such kind of study. So that was our what telling.
Yes, Dr. Mrityunjay, you're right. The literature also describes that once you give one local anesthetic and then you wait for some 90 seconds, or you wait for some few more seconds, like they have mentioned, the studies are also of this concept which have been done. Once you give a local anesthetic, let it bathe there, stay there, and then wait for 90 seconds and then give the other local anesthetic. Yes, the point is there, and probably this is what the researchers have mentioned in their original article. Thank you.
Yes, ma'am. Yes, thank you.
Thank you, Dr. Mrityunjay. Thank you, Dr. Madhul, for nice paper, and thank you, Dr. Vanita Uza, editor ICA, for taking it forward and bringing out some new points which can be food for thought for future research also. Thank you so much. Moving forward, over to Dr. Zulfikar Ali.
Good evening, everybody. Thank you, Indian College of Anesthesiologists and Dr. Rakesh, for organizing this webinar and giving me an opportunity to be a part of this webinar. Our next article, it will be presented by Dr. Naveen Vivek, and Dr. Naveen, he will be presenting his article, which has tried to compare the efficacy of 0.9% saline with balanced crystalloid solutions. And he has tried to study its effect, comparing the effect of these two solutions on the metabolic profile in patients who are undergoing surgery for acute subdural hematoma. Over to you, Dr. Naveen. Dr. Naveen?
Dr. Naveen, can you just unmute yourself? You're muted, please. Yeah.
Good evening, sir. Today I will be giving an overview of the original article published in the recent June edition of Indian Journal of Anesthesia. My research topic is comparison of efficacy of 0.9% normal saline with the balanced crystalloid in maintaining the metabolic profile in head injury patients undergoing acute subdural hematoma evacuation, a randomized controlled trial. The choice of intravenous fluid is important in traumatic brain injury patients where large volume of fluids are required for resuscitation. Traditionally, 0.9% normal saline have been favored in neurosurgical patients. However, its supraphysiological chloride content can cause hyperchloremic metabolic acidosis and acute kidney injury when infused more than 2 liters. This, when coupled with renal ischemia and a reduced GFR, can heighten the risk of acute kidney injury. Yet, plasmalite is an isotonic balanced crystalloid solution with the composition similar to plasma and maintains a more physiological metabolic profile than normal saline and do not worsen the cerebral edema like ringer lactate. This overzealous fluid administration can lead to physiological derangement with the further requirement of crystalloid and blood product administration, creating a vicious cycle and finally ending up in AKA. Hence, consideration of these factors is essential in the management of traumatic brain injury patients. Approximately 10% of traumatic brain injury patients develops AKA, in which 2% require renal replacement therapy. Hence, diagnosis and treatment of AKA is imperative to reduce mortality and morbidity. Routine conventional diagnosis of AKA was based on urine output and serum creatinine levels, but this is not useful in neurosurgical patients where hyperosmolar therapy will be administered and urine output cannot be a reliable indicator. And serum creatinine elevation can occur only after significant reduction in the glomerular filtration rate. Here comes the role of urinary biomarkers for early identification of the acute kidney injury. Even though certain biomarkers like NGAL, interleukin, and liver fatty acid protein and kidney injury molecule are available, but they are not specific. But newer biomarker like tissue inhibitory metalloproteinase 2 and the insulin like growth factor binding protein 7, which is exclusive to renal tubular cells, and their combination has shown promising results in accurate detection of AKA. However, there is possibility of literature on the utility of this biomarker in traumatic brain injury patients. With this, hence we decided to study to find out whether plasmolate is an efficacious than normal saline in maintaining the metabolic profile among head injury patients undergoing evacuation for acute subdural hematoma. Our primary objective is to compare metabolic profile between two groups, and the secondary objectives were to compare the brain relaxation score, renal function test, plasma osmolality, coagulation profile, and the urinary biomarkers between both the groups. After obtaining Institute Ethics Committee and CTRI registration, we have conducted this prospective randomized control trial in JIPMER in patients aged between 18 and 60 years of age, scheduled for craniotomy and evacuation of hematoma. Patients who sustained major thoracoabdominal injuries or long bone fractures and who had experienced pre-existing renal failure and dysarthrodemia, hepatic failure, and pregnant patients were excluded from the study. Out of 96 patients were assessed for eligibility, and of which 6 were excluded. Remaining 90 patients were randomized using block randomization and allocation concealment using smooth technique into either plasmolate group or NS group. Depending upon the group randomized, the patient receives appropriate maintenance fluid at the rate of 2 ml per kg per hour. And the standard general anesthesia was given as per institutional protocol, was followed for all patients. Invasive lines were secured and brain relaxation score were assessed by the operating surgeon. The following parameters from the appropriate samples and hemodynamic parameters were narrowed at different time points and mentioned in the table. Other additional parameters like blood loss during the surgery, volume of crystalloids given, and volume transfused, and the urine output were also noted at different time points. Our primary objective outcome measures for the assessment of metabolic profile were pH, PCO2, base excess, anion gap, sodium, and chloride. The secondary outcome measures were brain relaxation score, coagulation profile, renal function test, plasma osmolality, and the urinary biomarkers. Sample size was calculated based on the study conducted by Day et al. By comparing two independent means, considering the minimum expected difference in pH between the two groups as 0.0315 with a standard deviation of 0.05. The sample size was estimated to be 45 in each group with a 5% level of significance and 80% power of the study. Appropriate statistical tests were used for the following parameters as mentioned in the table. Age and statistical tests used were unpaired student t-test, proportion or percentage for categorical variables, and a two-way ANOVA technique, and Mann-Whitney U-test. P-value of less than 0.05 is considered statistically significant. Coming to the results, demographic parameters including the duration of the surgery and glasses muscle were comparable between the plasmolate and the normal saline group. With regard to the metabolic profile, pH bicarbonate base excess has shown statistically significant difference between both the groups with a favorable metabolic profile in the plasmolate group. Coming to electrolytes and plasma osmolality, the same with the sodium and the chloride levels, which are statistically significant between the group. However, in coming to brain relaxation score, it was found to have brain relaxation score were comparable between both the groups. The other secondary outcome measures like urea, creatinine, and urinary biomarkers like tissue inhibitor metalloproteinase 2 and insulin-like growth factor binding protein 7 has shown statistically significant between both the groups, favoring the plasmolate group. Discussion. Here our results indicate that plasmolate is better than normal saline in maintaining the metabolic profile in patients undergoing emergency craniotomy for evacuation of acute subdural hematoma without adversely affecting the brain relaxation. Traumatic brain injury is a global health issue associated with significant mortality and mortality. Hence, fluid administration in TBI patients has been a contiguous area due to correlation between the osmolality of the fluid and cerebral edema. Here, in the recent 2 randomized control studies conducted on neurosurgical patients, the authors found that the plasmolate maintain a better acid-base, electrolyte, and renal profile than normal saline, and our results were in agreement with these 2 studies. In this is a study basics randomized control trial on subgroup analysis, they found that balanced crystalloids were associated with higher 90-day mortality. However, this is increased mortality may be pronounced in GCS less than 6, and this study couldn't provide whether the requirement of renal replacement therapy was reduced or increased in balanced crystalloid group, which is an important endpoint in the study evaluating clinically important outcomes of fluid management. Normal saline, though preferred in traumatic brain injury patients, its indiscriminate use has been associated with increased risk of adverse outcomes. In these 2 studies, there is no difference in the incidence of AKI between the balanced crystalloid and the saline group. However, the saline group had a higher incidence of major adverse kidney events. This finding underscores the importance of choosing an appropriate crystalloid for resuscitation. In these 2 studies, among the various biomarkers available to detect acute kidney injury, urinary tissue inhibitor metalloproteinase 2 and insulin growth factor binding protein 7 has a sensitivity of 89% and a specificity of 95%. In these two both the studies, they found they used urinary biomarker. They found that lower urinary biomarker concentration in the plasmolate group compared to the normal saline group. However, none of these patients developed AKI. Coming to brain relaxation, there is no difference in the brain relaxation, and the findings are similar to our other studies. To conclude, plasmolate maintains a more favorable metabolic profile than normal saline in traumatic brain injuries without significantly affecting the brain relaxation score. And the serum creatinine and urinary biomarker were significantly lower in those who received plasmolate when compared to normal saline group. Hence, larger RCT may be required for the entire spectrum of traumatic brain injuries are warranted to further insights into the fluid management in these patients. Thank you.
Thank you, Dr. Naveen, for doing this wonderful study in which you have tried to show that 0.9% saline may not be normal saline in head injury patients. It may act abnormally many a times and may cause more harm. Basically, all of us, we have been conventionally taught that while resuscitating patients with head injury, it's better to avoid glucose-containing solutions, particularly in the acute stage, because most of the patients do have catecholamine-induced hyperglycemia. And also it has been seen that the infusion of ringer lactate solution, it may alter the osmolarity appreciably, and it may be harmful once it causes hypotonicity. there are certain things which once I was going through the article, I would like to clarify from you. One of the things is that while our secondary aims of the study is to see the incidence of acute kidney injury. And once we have taken the age group that we have taken an age group of 18 to 60. So the physiological profile of a patient who is having an age of 18 years and who is having an age of 55 to 60 years, it may not be similar. So could we made once, did you try to make some stratification with respect to age once comparing a post-hoc analysis once the study was complete and try to compare the incidence between the two groups? Could you make an attempt after completion of the study? For example, you took an age group from 18 to 30 years or 18 to 40 years and another age group from 40 to 60 years and see some differences between the two groups.
Yes, sir. Thank you, sir. We will possibly we'll do post-hoc analysis further.
Okay. And the second thing that could have made an impact on our study results was once we see the patient's data, there is no mention that I could come across from the time of impact of the injury to the point once the patient was operated, and the resuscitation status of the patient once we induced the patient once he was operated, because I did not come across any information whether there were any episodes of hypotension which were seen in the preoperative period, whether in the emergency waiting area or in the general ward till he was operated. And these episodes of hypotension, they could again lead to acute kidney injury and may alter our results once we make a final analysis. Did we make any attempt?
Actually, that is a limitation of our study, sir. So preoperatively, what fluid they are giving and what hemodynamic status we haven't taken into account in our studies. So that can be a confounding factor in further analysis. Might be that may be a confounding factor also, sir.
Fine. Thank you. What I found a very well conducted study once again. What I find from your study is that what we have tried to study is the tissue metalloproteinase markers and the insulin-like growth factor binding protein. So this is basically a stress marker for acute kidney injury, and you have correlated well these markers, and have found a significant change with the change in the metabolic milieu of the patients. And what I find we could, the future studies in our Indian scenario, we could plan some studies consistent with the other two markers. These are basically the stress markers that we have studied, but we could also go with damage markers, the damage markers of the kidney cells as hepcidin, which is coming in a bigger way, and hepatocyte growth factor. And then more importantly, the clinical functional markers, cystatin C and proenkephalin A. So the future studies, I find a good research idea for our youngsters, our postgraduate students, that we could concentrate on these markers where we do not have many studies, particularly in the perioperative setting. Thank you so much, and over to Dr. Rakesh for a further discussion.
Thank you so much, Dr. Zulfikar Ali, SKIMS Srinagar, and thank you, the researcher team for Chipma Pondicherry, for taking this good research. And I'm sure Dr. Prasanna mentions that financial consideration is always an issue. Yes, I agree. And probably that's why this is for all the listeners. The various research grants are being offered And the lines are open from DHR and ICMR nowadays. So those who wants funding can apply. The lines are open for applying to the funding research. So thank you so much. We'll move to the next one and over to Dr. Divya Jain.
Thank you.
Thank you, Dr. Rakesh, and ICA also for having me on board. So the next study is an RCT evaluating the efficacy of endotracheal tube cuff lignocaine in the prevention of post-extubation cough in children undergoing elective surgeries, done in JIPMER. So for this, we have Dr. Kavya Shri. So I request Dr. Kavya Shri to kindly go ahead with the presentation. Over to you, Dr. Kavya.
Thank you, ma'am. I would like to thank ICA Academics and ICA for giving me this opportunity to present my article. So it was published in May 2024 in ICA. The topic is efficacy of endotracheal tube cuff lignocaine in prevention of post-extubation cough in children undergoing elective surgery, a randomized controlled trial. Introduction. So pediatric patients are at higher risk of developing post-extubation airway complications, and this is because of the narrower laryngeal and tracheal lumen that can get occluded by mucosal edema after injury. Post-extubation cough can lead to many adverse outcomes, especially in ophthalmic surgeries, neurosurgical patients, and airway surgeries. Various pharmacological and non-pharmacological techniques have been introduced to prevent the post-extubation response. Intracuff lignocaine has been tried and found to be effective in both adults and children, but data are scarce on using intracuff lignocaine in microcuffed tube. So the primary objective of our study is to compare the incidence of post-extubation cough between intracuff lignocaine and intracuff air in children undergoing elective surgery under general anesthesia. The secondary objective was to compare the incidence of laryngospasm, desaturation, apnea, and hemodynamic response between the two groups. After getting institute ethics clearance from institute ethics committee, the study was registered under CTRI, and the inclusion criteria was pediatric patients belonging to ASA physical status 1 and 2, aged 1 month to 12 years, scheduled for elective surgery requiring endotracheal tube for general anesthesia. Exclusion criteria was active upper respiratory tract infection, bronchial asthma, congenital heart disease, previous laryngeal and tracheal surgeries, allergy to local anesthetics, patients undergoing cardiac, neuro, head and neck, and airway surgeries, patients with anticipated difficult airway, and those expected to require post-operative ventilation. Randomization was done with the computer-generated block random number table, and sequentially numbered opaque sealed envelopes was used for allocation concealment. Patients were randomized into two groups. Group C was the control group with cuff filled with air, and group L was cuff filled with 2% preservative-free lignocaine solution. Age-appropriate pre-medication and nil per oral instructions were given. In operating room, after attaching all standard monitors, anesthesia was induced either with IV propofol or sevoflurane in 100% oxygen. After administering muscle relaxants, endotracheal tube was endotracheal intubation was done using appropriate size microcuff tube using the formula age by 4 plus 3.5 by an experienced anesthesiologist. In both the groups, the microcuff was initially inflated with incremental volume of air and cuff pressure was monitored. The volume of air required to eliminate the leak around the cuff and to maintain a pressure of 10 centimeter of water was measured. In lignocaine group, the microcuff was deflated and reinflated with equal volume of 2% lignocaine. At the end of the surgery, the cuff pressure was measured again, and the difference between the cuff pressure from the baseline was noted. Reversal of neuromuscular blockade was done with 0.05 mg per kg of neostigmine with 0.01 mg per kg of glycopyrrolate, and tracheal extubation was performed. Outcome measures after tracheal extubation, the following parameters were recorded in both the groups by a blinded observer. So the primary outcome, the cough cough was defined as 2 or more episodes of violent coughing or an SpO2 value that fell below 95% during each coughing episode. Oxygen desaturation, SpO2 less than 95% for more than 30 seconds. Laryngospasm was graded according to the 4-point scale given by Sue BCH et al. Grade 0 was no laryngospasm. Grade 1 was tried during laryngospasm. Grade 2 was complete closure of vocal cords. Grade 3 was cyanosis. Apnea, cessation of breathing for more than 20 seconds, and heart rate and BP for every minute was measured. Sample size was the reported incidence of cough after extubation in pediatric patient was 40%. To find a difference of 25% in the incidence of post-operative cough, with a power of 80% and an alpha error of 5%, 50 patients were required in each group. To compensate for any dropouts, we recruited 120 patients with 60 in each group. Statistical analysis, the normality of the data was checked using the Komogoro-Smiro test of normality. Continuous variables were summarized as mean plus standard deviation or median plus interquartile range, depending on the type of distribution. Categorical variables were expressed as frequency and percentage. Between the groups, the categorical variables were compared using chi-square or Fisher-Exact test, and continuous variables were compared using student's t-test or Mann-Whitney U-test. Intergroup differences was analyzed by two-way ANOVA test. A p-value of less than 0.05 was considered statistically significant. Coming to the results, the demographic profile. So age, weight, and height was found to be similar between the two groups. There was no significant difference of the distribution of these three in the two groups. The post-extubation events in both the groups. There was post-extubation cough was found to be higher in control group as compared to intervention group, that was the lignocaine group, which was found to be statistically significant with the p-value of 0.043. Only one patient in the control group had a laryngospasm, which was a grade 1 laryngospasm. No patient in the intervention group had a laryngospasm. Oxygen desaturation was observed in 2 patients in the control group and 1 patient in the intervention group. There was no statistically significant difference between the 2 groups. In both the groups, none of the patient had an episode of apnea. The secondary outcome, so this is a line graph for showing the secondary outcome, that is a mean heart rate and mean arterial pressure at different time points post-extubation. So coming to the heart rate, baseline heart rate was found to be similar between the 2 groups. The difference between the post-extubation heart rate between the 2 groups from time points 1 to 5 minutes was found to be statistically significant. The baseline mean arterial pressure and the post-extubation mean arterial pressure between the 2 groups from time points 1 to 5 minutes was found to be similar between the 2 groups. Discussion. Our study demonstrates a significant reduction in post-extubation cough in group L compared to group C. However, the incidence rates of laryngospasm and oxygen desaturation was comparable in both the groups. The reduction in adverse events suggests the local effect of lignocaine on the tracheal mucosa. In our study, we maintained an upper limit of cuff pressure of 10 centimeter of water, which is lower than that of used in adults, which is 25 to 30 centimeter of water. This lower cuff pressure would have contributed to the lower incidence of post-extubation cough. Our study found that cuff pressure at the end of surgery was lower than 10 centimeter of water in group L, which was the intervention group, who underwent the surgery for more than 2 hours. The incidence of cough was also significantly less in these patients, despite the lower cuff pressure at the end of surgery. As the duration of surgery increases, more time is available for the diffusion of the lignocaine through the cuff to produce the desired effect on the tracheal mucosa. there are few limitations to our study. The plasma concentration of lignocaine was not assessed in the current study. Intracuff air was used in the control group, which led to insufficient blinding. We did not assess the duration of action of intracuff lignocaine on the tracheal mucosa and the potential risk of aspiration in the immediate postoperative period. Even though none of our patients encountered this complication, vigilant monitoring is warranted in the immediate postoperative period. Future research should also explore using alkalinized lignocaine as a superior option for cuff inflation in pediatric patients. In conclusion, intracuff lignocaine in microcuff endotracheal tube significantly reduces the incidence of post-extubation cough when compared to intracuff air in pediatric patients undergoing surgery under general anesthesia. Thank you.
Thank you, Yashri. So I would like to congratulate your entire team for conducting research on such a pertinent problem, which we pediatric anesthetists quite frequently face, that is post-extubation cough, post-extubation, leading to stridor also. So the study is like very well designed. It had a very clear objective of comparing post-extubation cough with the incidence between the intracuff lignocaine and intracuff air, and which provided a very focused research question. So to keep it crisp, I have just two things to highlight. One, we have a lot of literature on the use of intracuff lignocaine for post-operative sore throat or cough, but all the literature is with the use of PVC tubes, right? Even if we talk in pediatric patients or the uncuffed tubes. So during your search or preliminary data, did you come across any study telling us about the incidence of post-operative cough with microcuff tubes?
No, ma'am. We searched many articles, but we could not find any significant study. We found a study which there was the results was comparable between two groups. There was no significant difference found, but the result was comparable between two groups. There are very few studies done with microcuff tubes now for intracuff lignocaine. So what we found was it was comparable between two groups.
In the microcuff, because what we
Yes.
feel cuff is an ultra thin cuff. So, and this intracuff acts through diffusion. So
Yes, ma'am. Yes, ma'am. The thin membrane allows the diffusion of lignocaine through the cuff, and since the membrane thickness is significantly less than that in the polyvinyl chloride, so it adds to the advantage of the diffusion, and hence the local effect of lignocaine is most probably contributing to the decreased incidence of post-extubation cough in these patients.
But contrary to that, you did not find too much diffusion happening in your study. It was hardly 0.1.
Yes, ma'am. The lower volume of diffusion which was found in our study was we think it is because of the lower cuff pressure. So we maintained a cuff pressure of less than 10. Like 10 was the maximum limit. So in adults, usually we maintain a cuff pressure of 25 to 30 centimeter of water. But in this microcuff requires a low volume also for inflation, and the pressure maintained was very less. So the volume of diffusion could be less because of that. But if we allow for significant duration, if the duration of surgery is more than 2 hours, then definitely there is the volume of diffusion of lignocaine increases now.
So this point itself gives you a thought for the future studies, like
yes, ma'am. Yes.
How much diffusion occurs through the microcuff tube? What is the peak onset? Much duration it's going to last. For this, as you've already highlighted in your limitation section, that the plasma concentration of lignocaine provide actually a valuable pharmacokinetic data. And incorporating these assessments, not just at the end of the study, but I would say collecting blood samples at defined points would and then trying to tally it or compare it with the clinical outcomes can enhance our knowledge about the lignocaine exposure and the efficacy. Not just the efficacy, maybe also the safety endpoints of lignocaine. So you actually have future studies using 4% lignocaine or maybe a lesser dose of lignocaine for And the second important thing, which I could not understand, why did you select such a wide range from 1 month to 12 years? We know that intubation characteristics also play a very important role
Yes,
for
ma'am.
how the quality of extubation. Is the patient going to cough? So in a 1 month child, the intubation is going to be difficult, maybe. So we can generally have an experienced anesthetist who performs the intubation. We often use a stylet. So these are all unaccounted confounders which are added on.
Yes, ma'am. Yes, I do agree with that, ma'am. The wider range could have been cut down, and we could have done a smaller group of age group we could have done. But I think we can for it the further studies can be done to explore this.
Yeah, the outcome of intubation on the extubation characteristics, or in this study also, you could have employed a sensitivity analysis or maybe propensity score matching to just balance out those, adjust for those unmatched confounders which you had.
Yes.
So
Okay.
it's a very well conducted, very well designed study. And that this gives you an impetus to continue with this kind of a research in future.
Thank you.
Congratulations to you and your team.
Thank you so much, ma'am. Dr. Divya Jain, thank you so much. And thank you whole team from JIPMER Puducherry for bringing this good study, well-conducted study, and looking for more research and good ideas from the researchers teams at JIPMER. Thank you so much, Dr. Kaveshwari. Coming to the last important topic, and over to Dr. Aloka Samantaray. Dr. Aloka Samantaray. I think some technical issue. So we are coming to the last study, which is again an important study. It was coming from AIIMS New Delhi regarding the analgesic efficacy of classical interfacial pain block versus modified thoracolumbar interfacial pain block for lumbar disc surgeries. Interesting study from neuroanesthesia point of view. So Dr. Saurabh Mandal along with Dr. Mrityunjay Kumar will be presenting it. Over to you.
Let me introduce Dr. Saurabh Mandal. He's a postgraduate passer from AIIMS Delhi. Now he's doing DM critical care at AIIMS Jodhpur. So over to Saurabh.
Thank you, sir. Good evening, everyone. So can I share my slide?
Yes, please.
This is the award article. The title of the study is Analgesic Efficacy of
Saurabh, your
Classic.
slides are not being shared.
Now, sir?
Yeah, just make it full screen, please.
Make it full screen, Saurabh.
Yes, sir. Yes. Sir, it is okay?
Yeah, fine. Fine. Yeah, please proceed.
Then the title of our study is Analgesic Efficacy of Classical Thoracolumbar Interfacial Plane Block versus Modified Thoracolumbar Interfacial Plane Block in patients undergoing lumbar disc surgeries. It was a comparative randomized control trial conducted in AIIMS New Delhi. So patients undergoing spine surgeries usually have a diffuse and severe postoperative pain. As described by pain journals and spine journals, the pain usually persists for 3 days and is of severe nature. So we are yet to find the ideal regional anesthetic technique to counteract this pain. Many modalities have been tried, like the erector spinal plane block, paravertebral plane block, retrolaminar plane block, wound infiltration, and intratracheal opioid. In the recent years, interfacial plane block is coming up to counteract this pain physiology of the post-surgical post-spinal surgeries. One of these recent interfacial plane block is a thoracolumbar interfacial plane block, which was first described by Hand et al. In 2015, and the procedure was later modified by Ushima et al. In 2016. The main mechanism of this block is that it blocks the dorsal rami of the thoracolumbar nerve roots. This is a basic anatomy on which the block works. Actually, the spinal nerve is formed by the anterior and the dorsal nerve roots. So the dorsal nerve roots, when it exists from the intravertebral foramina, we can see the spinous process, and the sap is the superior articular facet, and TP is the transverse process. So at the junction of the superior articular process and the transverse process, basically these dorsal ramus of the spinal nerve roots splits into medial, intermediate, and lateral branches. And the position of this splitting is guided by the muscles such as the MF is for multifidus, LT is for longissimus, and IC is for iliocostalis. So in between the facial planes, actually this all the dorsal spinal nerve root branches, this is our area of interest and target of our block. So the classical TLIP block targets the nerve targets the muscular plane between the multifidus and the longissimus. So this is the sonographical image. The multifidus is the muscle which is between the spinous process and the superior articular facet, the D-shaped muscle, and the lateral to that is the longissimus muscle. So between multifidus and the longissimus muscle, if we inject the local anesthetic, that will be our classical TLIP block. And the modified TLIP block, once we go more lateral, there will be the iliocostalis muscle and the longissimus muscle. If we inject drug between the lateral two muscles, iliocostalis and the longissimus, it will be the modified TLIP block. So while we conducted our study, we conducted this study by first giving general anesthesia to the patient and then proning the patient, and we gave this block under prone position using USG probe, either linear or curvilinear. But during our study, we found out that both linear and curvilinear probes can be used, but curvilinear provides more better image. And the L3 or L2 was the plane where we gave the block. A 10 centimeter block needle was used, and 20 ml of 0.25% ropivacaine was used for each site. So this is a video of the block. This is the superior articular spinous process, and lateral and down is the superior articular facet. A D-shaped muscle which connects to this is the multifidus muscle. Lateral to is the longissimus muscle, and more lateral is the iliocostalis muscle. Usually we can differentiate this by the different ecotexture of these muscles. So the aim of our study was to assess the analgesic efficacy of the classical TLIP block versus the modified TLIP block in patients undergoing lumbar disc surgeries. The primary objective was the effect of the total perioperative opioid fentanyl consumption in the first 24 hours, which combined both the intraoperative and the postoperative opioid use for the first 24 hours. The secondary objectives was the time to first analgesic requirement after surgery, the visual analog scale scores for pain, intraoperative hemodynamic response to surgical incision, and incidence of drug-related side effects. The inclusion criteria was ASA grade 1 to 3, age of the patients from between 18 to 70 years, and patients undergoing lumbar disc surgeries. But a majority of our studies was done in patients who undergone TLIP surgeries, transluminal interforaminal fusion surgeries, from single level to 3-level disc surgeries. The exclusion criteria were patient's refusal, previous lumbar spine surgeries, extensive lumbar spine surgeries, BMI more than 35, history of opioid tolerance, contraindications to regional technique, and pregnancy and lactation. Total 100 patients was recruited for this study. Group C TLIP was the classical TLIP group, which included 33 patients. Group M TLIP was the modified lateral TLIP group, which included 33 patients. And Group C was the control group, who only received general anesthesia without any block. So this is the consort flow diagram. 109 patients was assessed. out of which 3 patients declined to participate and 6 patients didn't meet inclusion criteria. Ultimately, 100 patients were randomized. And conventional TLIP group had 33 patients, modified TLIP group had 33 patients, and the control group, which didn't receive any intervention, only general anesthesia, was 34 patients. The intraoperative part, the anesthesia was maintained with isoflurane in oxygen and air 50:50 ratio and MAC of 0.8 to 1.2, a heart rate and mean blood pressure of more than 20% of the baseline. Fentanyl of 0.5 to 1 mics per kg was used. We used 1 mics per kg fentanyl, and IV PCM 15 mg per kg and IV ondansetron 4 mg per kg was given half an hour before completion of surgery. The post-operative, we assessed if a VAS score of more than 3 was noted, a bolus of fentanyl 1 mics per kg was given, and it was followed up by IV PCA fentanyl. The PCA fentanyl rate was set, no bolus infusion was given, a bolus of 20 mics with a lockout interval of 15 minutes was given. So in 1 hour, 80 mics of total fentanyl a patient could use in the post-operative period. So results which we found, intraoperative fentanyl consumption, comparison between group C TLIP, MTLIP and group C. The conventional TLIP intraoperative fentanyl consumption was around 103 mics. Group MTLIP was 99 mics and group C was significantly higher, where we didn't use any intervention, was around 270 mics. A comparison between conventional TLIP and modified TLIP, there was no significant difference with a p-value of more than 0.5. This is the box plot diagram of the intraoperative fentanyl consumption. So post-operative variables, the VAS score on arrival to PACU, the conventional TLIP was VAS score of 3, modified TLIP VAS score of 4, and group C conventional group was 8. The time to first analgesic request in group C TLIP was 55 minutes. In group M TLIP was 135 minutes, and group C demanded first analgesia immediately. The post-operative total fentanyl consumption in group conventional TLIP was around 1000 mics. In group modified TLIP was 880 mics, and group conventional TLIP was 1100 mics. Comparison between conventional TLIP and modified TLIP, there was no significant difference between the two groups with a p-value of more than 0.5. This is the graphical representation of the VAS score on arrival to PACU. This is the time to first analgesic request with showing conventional group demanding analgesic in the immediate post-op period. This is the number of rescue analgesic boluses from the PCA pump, which shows comparable between modified TLIP and conventional TLIP, but conventional group showed higher requirement of analgesic boluses. The total perioperative fentanyl consumption, which was our primary objective, group conventional TLIP showed around 500 mics of fentanyl in the 24 hours period. Group modified TLIP showed 490 mics of fentanyl in the 24-hour period, whereas group convention group showed more than 1000 mics of fentanyl requirement in the 24 hours period. Between group conventional TLIP and modified TLIP, there was no significant difference in the total perioperative fentanyl consumption. In a study, in between the conventional TLIP group and the modified TLIP group, none of the patients reported any nausea and vomiting, whereas in the conventional group, where we didn't use any block, 62% of the patients complained of postoperative nausea vomiting. The total perioperative, in our study findings, the total perioperative opiate consumption till 24 hours, there was no significant difference between the both approaches of the TLIP group, whereas there was significantly higher fentanyl consumption in the convention group C. And there was no other drug-related side effect observed other than PONV in all of the three groups. The conclusion: the both approaches of the TLIP are comparable in comparison to the cumulative opioid consumption, acute pain intensity, and rescue analgesia requirement. TLIP block is clinically superior to no block technique. Now discussion. This is I have already discussed this anatomy before. So this was the first study which Handetal conducted. He recruited 10 volunteers and used 0.2% opivacaine 20 ml bilaterally. And this was the graphical representation of the spread of the local anesthetic, which he noted 71 centimeter at the 5-minute interval and 84.7 centimeters square at the 20 minutes interval. And caudal to cephalad to caudal spread in the 5 minutes interval was 1.8 centimeter and 20 minutes interval was 1.2 centimeter. This was the A image is at the 5 centimeter mark and B image at the 20 centimeter mark. The red area shows the spread, and in the literature it was mentioned that the classical TLIP once injected it the spread of the local anesthetic is from L1 to L5. These are the recent studies after 2015 conducted on the thoracolumbar interfacial plane blocks. Two meta-analysis was done. One was TLIP versus no block technique, where they found decreased in opioid requirements in 71.6% of cases, and TLIP versus wound infiltration, they found while using TLIP, opioid consumption decreased by 63%. In our study, we found that both conventional TLIP and modified TLIP had equal opioid consumption. We concluded the mechanism of blockage of the nerve roots were similar in both the groups, which was the point between superior articular process and the transverse process. There was a study conducted by SIFT-C, who conducted a study between erector spiny plane block and modified TLIP block, and this was a non-superiority trial, and ESPB didn't prove to be superior compared to the modified TLIP groups. So we would like to compare like our study TLIP superior to ESP block. The anatomy of it has a easier learning curve, and the injection spread is shallower with less complications, less risk of hematoma formation, and intraoperative spinal cord monitoring is not required because we were only preferentially blocking the dorsal spinal nerve roots. The take-home message, the TLIP block, both approaches are superior form of postoperative analgesia, greater patient comfort, and less opioid consumption and negligible side effects. We would like to suggest the routine use of TLIP block for lumbar disc surgeries. For future studies, we can give multiple level for extensive surgeries and in smaller volumes. Like in this study, we have only used up to 3 spinal levels, but in future surgeries, we can extend it up to maybe in scoliosis surgeries with smaller drug volume. Thank you.
Thank you, Dr. Saurabh. Dr. Aloka, you want to say? I think some technical issues. So when we talk about facial plane blocks, I think this is an interesting study which has come up for the spine surgical interventions, and the research has already proven to be a beneficial effect. Only thing that we need to look for in the future is, though most of these blocks are ultrasound guided, and some of the research is coming up that they see the spread along the targeted nerves. The various facial plane blocks requires different volume of drugs. So as of now, I think concrete research should also be focused on at what should be the volume acceptable for the spread of the drug along those facial plane. And when we talk about the volume, the earlier studies, when it was related to the brachial plexus or any nerve plexus, it was primarily the reduction of the volume of these drugs without having any impact on the sensory or motor or anesthesia, analgesia, whatever it is being used for. I think that's a future research. We need to look for the facial plane blocks also, including.
Maybe maybe you can use that diluted solution local anesthetic Plus, we can add some adjuvants, like the studies have already been done with the adjuvants like dexmedetomidine, dexamethasone. It has been tried and it has become more effective. And this block is very much becoming the part of the many spine surgeons. They are trying to do awake spinal surgeries, and there also it has got a very important role to play.
Absolutely. I think it's a promising effect, and especially when we are moving away from the use of the anesthetic agents and the local block is effective. I think this is one of the very promising tools that will become up. So thank you, Dr. Saurabh and Dr. Mrityunjay. So we are almost on time. I think it's time to hand over back to the organizers. Thank you all the speakers and all the editors of Indian Journal of Anesthesia for coming forward and taking some key points from the various research which has been published. Thank you, everybody, and back to Dr. Mukul Kapoor for the final remarks. Sir, over to you.
Thank you, Rakesh. It was an excellent, a combination of various types of studies, and I think we gained a lot from that. And I think the studies were generally very well conducted. There are a few points, takeaway points, which I like to add to things. One is don't make the study too complex in terms of objectives. Like all of you had one primary objective, definitely, but some of you had too many secondary objectives. The more complex you make it, the more the study becomes difficult to conduct properly. If you have too many and there are lots of the few things which are very rare, some complications which are very rare, but they were shown as secondary objectives. Don't show them. You can show them as adverse events or whatever happens. But rather than showing, talking about them as secondary objectives, I think that is also a bit wrong. Secondly, just a point, not that any of the studies had this, please do not use drugs out of the box without a clearance from the central body, that is the drug controller. The drug controller only is permitted to give you permission to use the drug which for non-indicated uses. So whenever you try to do a study in which the indication is not actually recorded in its pharmacology, please try to use it carefully and with proper permission. Your ethical committee is, I don't think, adequate for this thing. Ethical committees I've seen give clearances right, left, and center because they are dealing with bulk studies at times, especially in postgraduate institutes. Ethical committees are heavily overloaded and they tend to overlook lots of things. So look at that also. And of course, use the right statistical methods. Statistics is very complex. And unless you use the right statistical method for your study may not give you the right results. And you may fail to publish it in a good journal. But anyway, congratulations to all of you. Very well done. Good studies. And I think that is why your studies were chosen for presentation today. Thank you very much for all of you. And thank you very much, Rakesh, and also your team of editors who have been there with us, who have analyzed these studies very well. And in the end, I would also like to again thank Learnet for giving us this platform, for permitting us, as always, to use this platform. And they have always been very punctual. They have been very professional in their approach. I would like again thank them for that. And thank you, everybody, for joining. And I wish you all a very good night.
Thank you so much, everyone. And with all due permission, I'm closing the session here for today and looking forward to hosting you again. So good night.
Okay, thank you. Thank you and good night. Bye.
Thank you.